Hi, my name is Michael Ivan. I'm one of the neurosurgeons here at the University of Miami. I focus on brain tumors and skull-based tumors. Welcome to this week's Connectome of the week. Today I'll be talking about a tumor that involves some of the visual cortex and networks. This is a 54-year-old gentleman who presented after having a prior resection treatment of a grade 3 astrocytoma. Now it recurred and is growing. The patient has some mild headaches as well as word-finding difficulties, and we can see the lesion presented here. So it's in the left posterior temporal-occipital lobe, heterogeneously enhancing, very diffuse borders. And really this week we're trying to focus on what can we predict from the Quicktome and the Connectome on what this patient's deficits will be postoperatively. We've already covered the language network, which is mostly anterior to this lesion. But in this case, posteriorly and medially, we're really worried about the visual tracts and the network. And so what can we say to this patient who has some very minimal visual disturbances pre-op on what will happen afterwards? So after we turn on our tracts and parcellations here, I've identified the visual network and visual system, as you can see here. The visual system is actually very highly complex. It's an area that works towards common goals of turning light into recognizable shapes so the brain can really understand, recognize it, and interpret it for the rest of the decision making. At first it appears to just be a very single, straightforward area, but actually the visual system is made up of multiple functional areas that work together. They can engage in visual processing, analyzing motion, recognizing patterns, textures, faces, determining function, etc. So the visual nodes have a certain hierarchy of function to understand vision correctly. And what we think is when the vision is received from the retina and goes to the brain, initially it goes through the primary visual cortex and what's called the V1 node. Then it's passed to V2 and V3, and then eventually it parcellates out to the ventral and dorsal visual pathways. The ventral pathway is really called the what pathway because it's really the brain's ability to recognize what the object is and interpret it, such as faces, places, or letters. The dorsal pathway, however, is the how pathway, and this can preserve perception of movement and motion and depth. And so if you're driving a car and you're trying to understand the depth to the next stop, which would depth to a sign, and interpret these and make decisions, this is the part that's going to help you. So when we look at our patient here, we're able to isolate the visual network by highlighting it here. We can see as we go through the lesion axially that there is medially, posteriorly, and inferiorly, this network is surrounding the lesion. And the three-dimensionality of it also really kind of helps you see that it's not only just the posterior aspect that we have to be worried about, posterior medial, but it's also this inferior and also something superior as well. So it's hard for us to say, are these fibers in the tumor or not, and even harder to kind of awake map this part of the exam. But it's important to recognize the risk associated with removing this tumor, and specifically at the edges, and that the patient may have difficulty with not only with their speech, if there's edema in the frontal aspect, but also with vision. And understanding the difference between receptive or expressive aphasia and visual agnosia is critical for understanding kind of these networks and how they work. Again, we can use Quicktome here to, by a process of elimination, understand how much of the visual network is really involved in these components of the tumor. And so we can see that, by eliminating the dorsal stream, the medial stream, and the ventral stream, really these components that we're most worried with that were involved in this superior aspect of the lesion is just a very, very small component of the lateral stream. And by understanding what each parts of the visual system can do, we can really kind of give a percentage or a better idea of what the risk of surgery is for this patient. So here is the images of our preoperative T1 contrast MRI and postoperatively, and we can see again we did a very specific lesionectomy of this case. Tumor came to the surface. We used that corridor to remove the tumor. Case was done with awake speech mapping, and we did stimulate some speech on the superior anterior aspect of the lesion, which was where we stopped. Immediately, we also left this tumor that was associated with vision as well. Postoperatively, the patient had very similar visual complaints than preoperatively with no significant change. A few days of mild aphasia, which then recovered as the swelling went down over the next week. Postoperatively, his vision was the same as preoperatively. His speech, he did have some mild aphasia for the first couple of days, but as the swelling went down, this recovered to normal baseline. Postoperative for this case, we also loaded the patient's MRI to the Quicktome to really understand, are these networks still maintained? Again, it's hard for us to know what is supercritical, how much cortex or how much of the network we need to preserve and how much is important. But what's interesting was that in this case, again, through process of elimination, if we load the visual network and we go through each one of these on the left side, we can see that there are components of the ventral, medial, lateral, and dorsal network that are still maintained. And so it's not surprising that when the patient woke up, that many of his visual symptoms were exactly the same as preoperatively. Again, this just elicits how important it is to understand what the risk of surgery is and the complex networks that surround each tumor, and focus beyond just language to expand to such things as the visual connectome. Thank you again for tuning into this week's Connectome of the Week.